Welcome to the podcast for Healing Neurology, where we talk about everything that can help heal your neurology, which is really everything from food, lifestyle, and medicine to nature, culture, and politics. There's no topic too big or too small. I'm Jillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine. And we have with us, this is a somber sort of show today. We are going to talk about the realities of abortion, and our fantastic guest, Dr. Anuj Khattar, is a family medicine provider who specializes in reproductive health. He graduated from medical school at OHSU and completed his residency at Swedish Family Medicine, Cherry Hill. He also completed a fellowship in integrative medicine at Swedish Cherry Hill. He works both locally in Washington State, providing full spectrum family medicine, and has traveled to multiple states to provide reproductive health care. Dr. Khattar, welcome.
Thanks for having me. I know you said the word somber during your introduction, and I think for people's perspective, today is the morning that the Supreme Court released their final opinion on the decision for Dobbs versus Jackson, the Mississippi case, and they have overruled Roe versus Wade as precedent for abortion rights in our country, and now are allowing states to make their own decision, which means that half the country will unfortunately no longer have access to appropriate abortion care.
Like, that bit of silence is just to let that sink in. Regardless of when you're listening to this show, whether it's here on Friday, June 24th, 2022, or at some future point, today is the day that essentially Roe has been overturned, and it ends 50 years of reproductive health, of autonomy for women choosing what happens with their bodies. And I, for one, I'm totally in shock, although I know I shouldn't, because this has been coming for a long time. But just my heart aches for women not being able to choose what happens inside their bodies on a day-to-day basis. Inside our bodies is where pregnancy occurs. It is not something that is part of the public sphere. It is, I think, the public's job to protect pregnant women, but it is the woman's decision what happens with her body, with our bodies. So here is a little snippet that I'm going to read from an article that has been pre-published but is coming out in the July 4th, 2022 New Yorker issue. And it's called, "We're Not Going Back to the Time Before Roe, We're Going Somewhere Else." And it's by Gia Tolentino. So here's what she says, and I'm reading, most of the way through the article, but I just want to clarify sort of some of the things that we're discussing today. So she says this: "Pregnancy is more than 30 times more dangerous than abortion. One study estimates that a nationwide ban would lead to a 21% rise in pregnancy-related deaths. Some of the women who will die from abortion bans are pregnant right now. Their deaths will come not from back alley procedures, but from a silent denial of care, interventions delayed, desires disregarded. They will die of infections, of preeclampsia, of hemorrhage, as they are forced to submit their bodies to pregnancy that they never wanted to carry. And it will not be hard for the anti-abortion movement to accept these deaths as a tragic, even noble consequence of womanhood itself. In the meantime, abortion bans will hurt, disable, and endanger many people who want to carry their pregnancies to term, but who encounter medical difficulties. Physicians in prohibition states have already begun declining to treat women who are in the midst of miscarriages for fear that the treatment could be classified as abortion. One woman in Texas was told that she had to drive 15 hours to New Mexico to have her ectopic pregnancy, which is non-viable by definition and always dangerous to the mother, removed. Misoprostol, one of the abortion pills, is routinely prescribed for miscarriage management because it causes the uterus to expel any remaining tissue. Pharmacists in Texas, fearing legal liability, have already refused to prescribe it. If a miscarriage is not managed to a safe completion, women risk, among other things, and taking the emotional damage for granted, uterine perforation, organ failure, infection, infertility, and death. Most miscarriages are caused by factors beyond a pregnant person's control: illness, placental or uterine irregularities, genetic abnormalities, but the treatment of pregnant people in this country already makes many of them feel directly and solely responsible for the survival of their fetus. They are told to absolutely avoid alcohol, coffee, retinol, deli turkey, unpasteurized cheese, hot baths, vigorous exercise, drugs that are not prescribed to them, drugs that they have been prescribed for years, often without any explanation of the frequently shoddy reasoning behind these prohibitions. Structural factors that clearly increase the likelihood of miscarriage, Poverty, environmental chemical exposure, working night shifts are less likely to come up. As fetal personhood becomes law in more of the land, pregnant people, as Lynn Paltrow, the director of the National Advocates for Pregnant Women, has pointed out, quote, could be sued or prevented from engaging in travel, work, or any activity that is believed to create a risk to the life of the unborn, unquote. I could have a whole 60 minutes of silence just for out of shock. So I think we should move into some information, though. Podcasts that are silent are not generally going to be listened to. So, and we have you today, and you're an incredible resource. So let's dive in. I will cry later and often, but let's dive in and let's talk about abortion. Why did you become an abortion provider?
Yeah, it's a great question. I didn't grow up knowing that this is something I wanted to do. When I was younger, I thought I was really interested in science and I thought I was going to do research, but I spent a lot of time working in labs when I was in undergrad and realized that I missed the human connection. So I decided to pursue medicine after having volunteered for many years working with homeless and unhoused populations in West Hollywood. And I felt like the best way I could be an advocate for people who didn't necessarily have a prominent voice in this country is by becoming a physician. While I was in medical school, I found that when I was on my pediatrics rotation, I was seeing a lot of child abuse or non-accidental trauma and broken bones and broken spirits. And it was really hard for me to understand how people could do this to their own children. And I think that's from me growing up in a very sheltered house where I was a wanted child and I was a loved child, and recognizing that's not always the case for a lot of families. That led me to do some more research into undesired pregnancies and lack of access to contraception, lack of access to family planning and abortion. And that made me realize that this is a way that I could help identify and reduce trauma for many people at a root cause. And that's why I went into reproductive health care.
So let's talk about what is the scope of reproductive health care in terms of around pregnancy.
Pregnancy has a lot of different options. The most common option is for people to continue their pregnancy. And for that, you need adequate prenatal care and monitoring to make sure that it's a healthy pregnancy. But if somebody continues a pregnancy, it doesn't mean that they have to parent. Adoption is always an option for people if they feel like they're not in a space to parent. And the other option with a pregnancy is to stop the pregnancy or terminate the pregnancy to allow that person to have full reproductive autonomy and decision-making over when they choose to parent.
Great. And so what is an abortion? Can you kind of define that for us? And what are the options for making that happen?
So an abortion is the removal of the fetal tissue that's inside the uterus, and that can happen at many different stages in pregnancy, very, very early or later on in the pregnancy, depending on the situation. There are two primary options for abortion procedures. One is the medication, which is a combination of mifepristone and misoprostol. And the second is an in-clinic procedure or a uterine aspiration, often also referred to as a surgical abortion.
And so is Plan B, the emergency contraception pill, is that an abortion?
No, that's a great question. I think there's a common misconception in many people's minds that taking the morning after pill causes an abortion to occur, but that is not the case. Plan B is a dose of synthetically made progesterone. So it's a hormone that many people with ovaries already produce. And that hormone, what it does is it delays ovulation. So it prevents an egg from being released. So it decreases the chance of fertilization occurring. Okay. So it prevents there from being an egg for the sperm to attach to.
Okay.
And that's the same. There's a second, I'm just going to put a plug for the second emergency contraception called Ella, which is olapristol, which is a synthetic chemical, which does similar things by preventing ovulation. And that one's actually more effective than Plan B, but it's required to have a doctor's prescription or a healthcare provider's prescription. So ask your providers about that if that's something that you're interested in.
So Plan B is available without a doctor's prescription?
Correct. It's available over the counter. You can request for it at the pharmacy. There are some stipulations that I think many people don't know about. but one of them is if your BMI or your body mass index is above 28, the effectiveness rapidly decreases. So for people who are overweight and obese, it's not a very effective form of emergency contraception. Still better than nothing, but I've seen many people in clinic who are like, but I took Plan B, how am I pregnant? And it's just not as effective. So I want people to be aware of that.
Got it. That's super helpful. Is Ella any more effective for elevated?
Ella is significantly more effective in people who are obese and overweight. However, it's still not 100%. We don't know exactly how effective it is, but we know that the effectiveness starts decreasing after a BMI in the 30s.
Got it. And a person can figure out their BMI just by going to Google and typing in BMI calculator and putting in their height and their weight, and it'll give you a calculation.
Exactly.
Okay. So that is contraception, emergency contraception. There's also contraception. Can you talk to us about some of the other types of contraception and whether they essentially are like an abortion or whether they're preventing?
Yeah, so there's a lot of different types of contraception. There's hormonal and non-hormonal contraceptions, and some people have very strong feelings about what their bodies can tolerate. And I think as healthcare providers, it's our job to help navigate people to something that works best for them. I think some of the more classic and older forms of contraception are barrier methods. So condoms or female condoms. There's spermicides that are non-hormonal as well. And there's a new one called Phexxi that was just introduced that has a very high effectiveness rate, but that requires a healthcare provider's prescription as well. So you can inquire about that. Some of the hormonal forms of birth control are either combined, which means it contains both estrogen and progesterone, or progesterone alone. Some people's bodies may have side effects or sensitivities to different hormones, even though people's bodies naturally produce them. What those hormones are doing are they're suppressing your body's ovulation. So they're preventing you from releasing eggs every month so that you decrease the risk of becoming pregnant. None of these contraceptives are 100% effective. There is always some level of failure, whether it's user error or the medicine itself. But with some of these, there's options like the pill. There's options like a ring that you can place into your vagina that slowly releases those hormones. There's patches that you can put onto your body. There's implants that you can put into your arm or implants that you can place into your uterus. Those are the more common forms of birth control. And I think inquiring with your healthcare provider what's best for you is the best way of going about it.
Okay, so talk to us a little bit more about abortion in terms of, talk to us about when do abortions happen in pregnancy?
Abortions happen at any point of pregnancy. Some patients are very sensitive to changes that happen in their body and are able to recognize a pregnancy very early on and seek abortion care starting at 4 to 5 weeks of gestational age, which is sometimes very challenging as an abortion provider because there's very little to see in the uterus, and it's hard to confirm that somebody is no longer pregnant after the procedure if there's no tissue to see. There's also people who receive abortion care later in their gestation for fetal anomalies or maternal health or other reasons that cause them to not be able to safely continue the pregnancy.
And so what percentage of, or kind of ballpark, of abortions are happening kind of in which trimester?
Great question. So 90% of procedures for abortion are happening in the first 12 to 14 weeks. So the first trimester of pregnancy is when most people are having their abortion procedures. And the minority of abortions done in the United States are done after that gestational age. But putting any restrictions on abortion access and gestational age limits is really detrimental to the health of people because a lot of fetal anomalies, genetic anomalies can occur later in pregnancy or are not detected until about 20 or 22 weeks of gestational age. So to force somebody to continue a pregnancy with a fetal anomaly that will cause a neonatal demise or a fetal intrauterine demise is really unsafe for people's health or mental well-being. So having the option to terminate a pregnancy if they know that they're reducing the suffering for that fetus, I think is a really interesting thing to keep in mind as well.
I think part of this podcast is about learning the science and the reality, and part of it is counteracting what we're hearing in the media. And I think one of the things that we hear in the media is kind of like, well, if we don't restrict the gestational age, then at 39, if a pregnancy is 40 weeks, at 39 weeks and 6 days, a person can say, I'm done being pregnant, take this baby out of me. Like how realistic is that? How often does that happen?
That is not a real sentiment. I think our country fails to recognize in many ways that women can make choices for themselves. And that's, I think, a very sad reality that I see of America. Maybe not everybody else sees that. People do not take the decision to have an abortion lightly. Pregnancy, many people try to prevent pregnancy, but the ways that they're using to prevent pregnancy may not be completely effective. And unfortunately, many people in our country don't even know how they become pregnant. And I'm speaking, having many patients have asked me in clinic, like, how did this happen? And it's just mind-boggling to me. We don't really have a great education system. And with some of our states that only allow abstinence-only education, people haven't learned how pregnancy occurs biologically. So there's a lot of different things going on there. Even though people may not know how they got pregnant, many people understand whether or not they're ready to parent. So people have cousins, relatives, etc. People have been around kids. They know what they can and cannot do with their own lives, and they may have their own aspirations of their own. So the decision to have an abortion isn't taken lightly by any person who is able to be pregnant. And when people are coming to the clinic for an abortion, they've already thought a lot about this decision. It's not something that they're deciding on the dot or just being impulsive about. And if somebody has been pregnant for 30 weeks, like their body has already had a lot of changes and they've had a lot of time to think about it. So it's not something people are choosing to do later on in pregnancy. They've already suffered from the morning sickness of the first trimester, or the changes to their weight, or a lot of bodily changes that are occurring from pregnancy. So I think it's silly to think that people are waiting that long in pregnancy to make an impulsive decision like that. And it's not an impulsive decision to have an abortion.
And so there's two question lines I want to follow up on. So one is that this is not a decision that women are taking lightly. So women are thinking about this, and this is something that you've seen in the care that you've given. Is that right?
Correct.
Okay.
People think about this. I see many patients who show up to just have a conversation and they need more time to think about it, and they go home and they'll be back in a week or two, or maybe they won't be back because they decided it's not right for them to have an abortion and they're ready to continue a pregnancy. Yeah, people do not take the decision to parent lightly or to be pregnant lightly.
And what I'm hearing from you is that some of the late stage abortions, that we're hearing about in the media, like the person who just says, I'm changing my mind. A lot of what's really happening there is that there are fetal anomalies. So something is wrong with this fetus makes it not compatible with life. And so then it becomes a danger to have fetal demise in the uterus, or it makes it just difficult to persist with a pregnancy that's not going to end up with a live baby. Is that right?
Correct.
And so it really is an act of compassion to be able to end this pregnancy.
For many people it is. And many of our patients also view it as an act of compassion. And for many of these patients, it was a very much desired pregnancy. And there is a lot of sadness around it when they choose to have an abortion, but they recognize the compassion that they're providing in that situation as well.
And there was just to make this even a broader conversation, there was a great article in the Huffington Post, I think either this week or last week. And it basically was saying that anytime we judge whether a woman's abortion is appropriate or not appropriate, we are a third party making a judgment on a person's body who we don't really know. So there's stories in the media like 11-year-old impregnated by her father, she deserves an abortion, but somehow that implies that there is a woman who doesn't deserve an abortion or doesn't deserve autonomy over her body. So is it really relevant why the abortion is being sought?
In my opinion, no. My job as a healthcare provider is to make sure I'm providing safe healthcare and accessible healthcare to my patients when they need it. And the reasons don't matter to me. And I've gotten to a point where I've heard so many explanations and reasons that I've stopped Like I've asked patients to be like, you know what, your reason is yours. I don't need to know. If you want to share with me, I'm happy to share, but you don't have to give me any reason or excuse for why you're proceeding with this today. And I think the important thing for this decision for patients is like, are they ready to change their lives this way? And if the answer is no, then whatever reason it is for somebody to receive an abortion is not for me to judge. This is a life-changing decision to parent, to be pregnant. And if somebody knows that they're not ready for that life-changing decision, then I'm there to support them in that. And I understand what you're saying with the media portrayals and the judgment of a third party. And I think that that creates a lot of morality that is very unique and based in people's own worldviews and religion, possibly. And those judgments aren't for us to make. I think we should allow people to make choices for their own lives.
Absolutely. Can you just repeat that last sentence you said? Because it really should be said twice.
Yeah, we really need to allow people to make choices for their own lives.
With the Supreme Court overturning Roe today, women's options essentially have changed in many states, or are changing or about to change. Can you talk to us a little bit about what illegal abortion has been like or will be like, or how we learn about that?
Yeah. So for those listening, if you've watched the movie The Janes, it was a documentary that was released last year. I think that's a great way to get an understanding of what the United States was like in regards to abortion access prior to Roe versus Wade being passed. But it was challenging. There were underground networks for people to get connected to providers who were providing abortion care, which weren't always healthcare providers, and patients weren't always left in the most safe and comfortable positions after their procedures. What legalization of abortion did was it allowed regulations for abortion and surgical abortion to be placed, making the process much more humane and comfortable for patients. The future of abortion care in regards to states where abortion may not be legal will look completely different with the advent of some new pill medications. I think it's important for people to know that abortion by pill is very safe and effective and is very accessible. And there are a lot of different ways that people can access it through different means. And I unfortunately don't know what those are, but I am aware that patients have been able to receive them and obtain them either from this country or other countries, because I see those patients in clinic for follow-up or other issues and whatnot. Okay. So I know it's happening. I just don't know how it's happening.
And you can take the pill how late, how many weeks along?
The FDA has approved the pills for up to 10 weeks in pregnancy. However, there is evidence in science saying that it can be used further along. And in many countries, those pills are used quite far along in pregnancy, up to sometimes 20 weeks. And it depends on access to different care. So there's something called an induction abortion that is done in many hospitals and places around the world, where if the patient has a fetal demise or a miscarriage at any point in pregnancy, they can be given misoprostol, which is the second medication of the medications to allow the pregnancy tissue to pass on its own. So that is a very commonly performed way of abortion in medical settings. And I think it would be more challenging for patients who are further along in pregnancy to have that sort of process at home. But there will be ways for patients to travel. I don't think there's necessarily going to be underground networks for abortion access with this ruling, because abortion will still be legal in about half the country. Mm-hmm. So what we're going to have are networks for patients to be able to go to the places where abortion will still be legal.
And so if you're pregnant and you're not interested in being pregnant, those are, the network to a state where it's legal, or finding, I'm assuming the internet is involved, but
the internet is always involved. This is our world now.
I saw a sign on a telephone pole the other day that said "End the internet." Just thought, my God.
Yeah.
The other option essentially is what people are really calling forced birth, which I think that's what it is. You don't want your body to be doing this, and your body is doing this.
Yeah, forced birth is traumatic. I don't think people recognize that the C-section rate is anywhere from 20 to 30%, and variable depending on where you live. So it's potential major abdominal surgery, life-changing surgery. people's bodies change with pregnancy. Yeah, forced birth is a real thing. Forced pregnancy will be a real thing coming soon.
Can you talk a little bit about what some of the, I mean, we mentioned them earlier, but just to talk about like when you're pregnant, what happens in your body, what physiologically?
There's a lot of changes that occur in the body. There's, your connective tissue changes, it gets softer, it becomes more malleable as your body is preparing for delivery. There's breast development and engorgement as the breasts are preparing or chest is preparing for feeding. People gain weight, people have hormonal imbalances, people become irritable. There's a lot that occurs. I can't say I know any single healthcare provider that has been pregnant around me who's been like thrilled with their pregnancy. Most people are like, oh, how did this happen? Like, I didn't know these things were going to change in my body. I didn't know this was going to occur. So it's a surprise. I think we don't do a great job as a society telling people how different their bodies will be throughout this process. And another common thread that I hear is feeling like people's bodies aren't theirs during pregnancy. They feel like it's kind of been commandeered by another person, especially postpartum, when people are feeding and they're just constantly attending to a newborn. It's a lot of work.
It's an incredible amount of work. There was another article I read where somebody had logged their hours breastfeeding, and I think just breastfeeding. And I think just feeding a baby, just breastfeeding, which I think it was something like a full-time job. It was, 8 hours over a day for every day of the week. And that doesn't even include diaper changes, clothing changes, bathing, supplies. It's expensive to be pregnant and have a baby. Just to kind of add to what you were saying, the weight gain is real. So, our government is essentially mandating that women gain at least 15 pounds. If not, some women gain 80 or even 100 pounds. And so the government is mandating that you gain weight. The government is mandating that you increase your calorie intake, your food intake, because now you're having so much more metabolic activity. So you need money to pay for all that food. And also with breastfeeding, when you're lactating, you're also having increased calories. There is an incredible amount of fatigue that can come, especially in the first trimester. I remember at one point being at work and having one of my colleagues talking to me and just thinking like, are my eyes still open? I think I'm falling asleep. Like, it's just sitting at a chair at work, talking to a colleague who I really like, who I was really interested in what they were saying, but my body was busy doing something else. And I was happy to be pregnant. I had wanted to be pregnant, but there are things that shift. You can't sleep in certain positions. Your balance is off. You can't exercise the way that you were. You can't fit into your clothing. You need new clothing at some point or somebody else's clothing. So it's a lot of work. It's a lot of time. It's a lot of stress on the body, and it's a lot of money. So
absolutely. And I think an important point to note is that the majority of people in the United States having abortions are already parents.
Mm-hmm.
Those people who have been pregnant before. So about 60% of people having an abortion have already had a child. So they know the changes that are happening to their body throughout that process.
So when we talk about what's being mandated with forced birth, it's all of those things. Let's talk about some abortion myths and some truths. Can you talk to us a little bit about when you were providing care, some of the things that you were mandated to say?
Yeah, in some states like Texas and Tennessee, where I have traveled to work, there is a script that is required to be read to patients as part of a mandatory waiting period. So luckily, being in Washington State, there aren't any excessive rules or regulations in that way that aren't science-based. But in many other southern states prior to this blatant banning of abortion in a lot of those states now, there were mandatory waiting periods, whether it's 72 hours, 48 hours, 24 hours. I was required to read a script that would often say things like, some experts say that having an abortion increases your risk of breast cancer or other cancers. And I would always have to stop the script and say, as a healthcare provider who has looked at the research, that is not true, but I am required to tell you this information per the state. So there's a lot of falsehoods that exists and a lot of fear. I think what the anti-choice movement is trying to capitalize on and win through is fear. They're trying to make people scared for their own health so that they continue the pregnancy, and not allow people to actually make a decision that's best for their own health. There are, as you mentioned from this previous point, like long-term consequences to people's health from being pregnant and carrying a pregnancy to term, but those don't necessarily exist if people choose to terminate the pregnancy.
So does abortion cause cancer?
No, it does not.
Does abortion lead to infertility?
No, there is a condition that can cause uterine scarring to occur, which can cause infertility. That was much more prevalent pre-Roe versus Wade being enacted, just because of how abortions were being performed. So that is an extremely rare thing that can occur, and it does not occur with our advanced surgical techniques and medications that exist. So no, I would say no, abortion does not cause infertility.
If the pregnancy is a result, or if there is a rape, can a woman decide that that pregnancy doesn't stick?
No, I think what you're referring to is what some policymakers were talking about. I can't remember what state this was in, but there was a politician saying that women could will their bodies to shut off ovulation or prevent fertilized embryos from attaching to the uterus, and that is not anything that anybody has mental control over, unfortunately. So pregnancies do occur from rape, and even if a woman does not want a pregnancy to occur, they really have no control over what happens once that egg is fertilized. Okay. It can attach, but many times it won't too. But rape is bad and wrong and terrible, and to have politicians think that people can have control, physiologic control, is so strange to me.
Are there any regulations? Really what we're talking about with pregnancy is you do need sperm. You need an egg and you need a sperm. Are there any regulations on sperm?
Great question. I don't think at this moment there are.
Can you define what an ectopic pregnancy is, and can it be reimplanted into a uterus?
So an ectopic pregnancy is a pregnancy that has implanted outside of the uterus. The most common area where that occurs is the fallopian tube, but it can also be in the cervix or outside of the uterus. Ectopic pregnancies are considered a life-threatening condition because once they get to a certain point of growth, they can burst and cause a lot of severe hemorrhaging intra-abdominally and potentially increase the risk of death for the patient. Ectopic pregnancies are not pregnancies that can be removed and reimplanted into the uterus. And I think you're also referring to a politician who made some bogus statement about how we should be saving every ectopic pregnancy and reimplanting them. And they are not speaking through medical science.
Can you think of any other myths that we should bust right now?
Yeah, the other important study I feel like we should bring up is the turnaway study. I don't know if you've looked into that. But it was a study done through the University of California, San Francisco, and it was a demographer, Diana Green Foster, who did a lot of research and evaluation into patients who were denied abortion access, and found that in the short term, people who were denied abortion had greater rates of depression and anxiety, and worse mental health outcomes. But eventually, the mental health was similar for patients who were either denied an abortion or provided an abortion. However, the physical health outcomes and the financial economic outcomes of people who were forced into pregnancy were significantly worse compared to people who had access to abortion. If you talk about, money and finances being a socioeconomic factor for health and people's well-being, people who have those worse socioeconomic and financial outcomes aren't going to be able to be in a better place for their own health. They're not going to be able to take care of themselves better. So you are denying people the ability to have a better life in that way when you're forcing them into pregnancies if that's not what they want.
And it does. I mean, pregnancy and caring for a newborn or sometimes twins, it absolutely interrupts the capacity for women or people to work, to make their living, be able to feed the children that they have. So that's another way.
It's hard. And I know we're talking about pregnancy being this big thing, but if it's a desired pregnancy, we should also have the support systems in place to help people.
Absolutely.
So how are we expanding access to paid parental leave? How are we expanding access to support services for people who want to parent? I think that's the other conversation that needs to happen in every state now. So I feel like the resources are also limited for people who choose to parent, and we need to do better at that too.
Oh, I absolutely agree. It is unbelievable to me still about how hard it was to be a new mom. I couldn't believe there was so little support, how much work it took, and how little support there just is societally. So when we think, we're such rugged, we come right from this place in the United States of this rugged individualism and these nuclear families. But what that means is that we really don't necessarily have any community built in or a value for community to be able to take care of kids, to take care of new moms, to take care of our elders. Our society is built of people of all ages and all capacities. And so what we want as a healthy society is to be able to take care of all of our communities, all of our people.
Absolutely. I mean, I can only imagine a day where we'd have free universal childcare and like preschool, and like that's what would allow people to be who they want to be and to be able to work if they want to work, and like to just have space and mental clarity sometimes, because having a young child takes a lot of brain energy.
If we truly wanted to decrease the number of abortions in this country, what could we do? What are some things that we could really focus on?
There have actually been a lot of studies on this, in what actually is able to decrease pregnancy rates in teenagers and people in general. But I think one of the biggest markers often that's looked at is teen pregnancies. But Colorado did a big study and showed that increasing access to contraception and good health education was the biggest factor for decreasing pregnancies that were unwanted. Teaching people how we get pregnant will allow them to make better choices. And it's frustrating to me that we have such a large vocal opponent to teaching like accurate sex education. I think it's such a shame that our society isn't able to teach people how their bodies work and what their bodies do. And it forces them into this place of, allowing their hormones to take over and not really know what's going on. And that's scary to me, is I want to know how my body works. I imagine that people around me want to know how their bodies work too. So why can't we teach them?
I think it's also important to recognize that intimacy and sex should be pleasurable, should be fun, should be nice, there's other ways that we kind of shame people who like sex. And I think that also is weird.
Absolutely. I think we need to trend towards a more positive sex culture in our country too. And I think that will also allow us to make better informed decisions with our bodies, just to be more accepting of like what the variety of sexual pleasures are that people can have and do have.
And we did the podcast, actually, we recorded last week with Acharya Shunya, who's just written a book called Roar Like a Goddess. We talked a lot about this. I think that we get stuck in this place where we either have to shame sex, or it has to be like people can have orgies on the sidewalk. And there is...
I think there's a lot of space in between.
There's a lot of space in between. And so having pleasurable sex with dharma, that's what we had talked about, with consent, with intention, with embodiment. There is a way that, this is not like pedophiles and sex rings or abstinence only sex education, that there is the reality of what sex and intimacy can and should be, including the interactions, the sexual interactions that can lead to pregnancy or do lead to pregnancy. We can have a much more reality-based view of knowing what our bodies do, knowing how they work, engaging in the sexual experiences that we're interested in, that we feel good about, in the ways that are appropriate in the ways that are amenable to everybody who's involved, and then making decisions about what the outcomes are, I think is the best way to prevent unwanted pregnancy and then to decrease abortions.
And access to contraception.
So, in access to contraception. So it always makes me think of when I was in nurse practitioner school. I worked with one of the high school nurse practitioners at one of the big local high schools here in Seattle. And literally every high school student that came in for a Tums, for a headache, for a Tylenol, for a sprained ankle, she was constantly like, would you like contraception with that?
Yeah.
So she just tried to kind of slap a patch on, everybody that came through, like, something. She said that there were about 8 high school pregnancies a year in her school. Mm-hmm. So in a 9-month school year, that's about 1 a month. And that was with all of the work that she was doing. So access to birth control, accurate and authentic sex education. The other thing I just want to mention that you and I had talked about before the show was really education and literacy for women. Can you speak a little bit about that, what the studies show?
Yeah, I think I remember you saying one of the biggest factors for decreasing birth rates and pregnancy around the world is countries that have higher levels of education and literacy. So I think allowing people to get educated and have their own goals and ideals and treating people with uteruses as if they're actual people that contribute to our society will allow a lot of this to kind of settle on its own.
Yeah, and to make choices. If women have other things to do other available opportunities.
Yeah, we're seeing more people in the workforce, more people in business who identify as women or have uteruses. And I think it's also making us a more rational country in some ways, though, as you can see, today was not a very rational decision. So it's interesting. I feel like in many ways our country is making progress, but for some reason we are stepping backwards in a lot of other ways.
Yeah. And I want to reiterate that there is nothing wrong with having many, many children.
Absolutely not.
It is just what studies have shown is that when we teach women how to read around the world, birth rates decrease. Mm-hmm. And whether that is what it seems to say is that as women have more options for their lives, the choices that they make include decreasing the number of children that they bear and care for and raise.
And just quickly going back to the statement about the high school pregnancies, like maybe some of those people wanted to be pregnant.
Absolutely.
And yeah, we just don't know, right? So I'm not trying to shame people for being pregnant. I think
yes.
Pregnancy can be very joyful if it's desired, but it's not desired for everybody.
Yes. And I think the statistic still stands that 50% of pregnancies in the United States are a surprise. So
Absolutely.
This is not something that was an intentional outcome. This was oh, okay. And then people have to decide what they want to do. And I think what we're talking about now is that if what we are trying to do is decrease the number of abortions that women are seeking or that women have, then education, literacy, authentic, accurate sex education, and access to contraception and autonomy, physical autonomy. If we can decrease the amount of sexual assault for women, then we can remove unwanted sperm from the vaginal canal.
Absolutely. Well,
wow.
Thank you so much for having me. I know this was a big conversation on a big day, but I appreciate that you're willing to have it. And, maybe we can follow up if things change.
Oh my God, I hope so. This is really about autonomy and choice for women and for families. And our perspective here is really that no government should have the capacity to tell a woman how much weight she has to gain, how much food she has to eat, and all the other conditions that come along with forced birth. So,
and I will expand that statement into people who are trans who have uteruses because they get pregnant too.
Yes, absolutely. All right. Well, everybody, we love that you've joined us today to discuss how to make our whole world medicine. We rise or fall together, and we're committed to doing what we can to make as many of us as healthy as possible. And this takes all of us, including you. Thank you for listening, and we'll see you next time.
Fish Media. Partyfish Media acknowledges that it operates and records on indigenous Duwamish and Puget Sound Coast Salish land that is still home to the Duwamish tribe. This land is stolen in violation of the Point Elliott Treaty of 1855. We are committed to uplifting the name of these lands and community members from these nations who reside alongside us. For more information on this land, its people, or ways you can help, visit duwamishtribe.org or realrentduwamish.org.